Okay. So in reviewing the right heart, we're gonna look at the right ventricle. Of course, we're gonna look at the size and the function, how to assess the size of the right ventricle, how to assess the function of the right ventricle. We're also going to look at the right atrial size, how to measure the size of the right atrium. We're going to look at the tricuspid valve. So we're going to look at the lesions that the tricuspid valve is subjected to, tricuspid regurgitation, tricuspid stenosis, and the same thing with the pulmonic valve, pulmonic stenosis, pulmonic regurgitation, and then the inferior vena cava. So it's a comprehensive review of the right side of the heart. And your report should have a fair amount of assessment of the right heart. So make sure that all your reports have some amount of right heart assessment. So of course, just going over the anatomy and physiology, the right ventricle receives blood from the right atrium through the tricuspid valve. So if we look at disease that affects the right ventricle, um, uh, what you have to understand is that the right ventricle is not just a passive conduit, because if the right ventricle is not functioning properly, you cannot get blood to the left side of the heart. The right ventricle have to be performing its job for you to get blood to the left side. So remember, the right ventricle also contracts and is going to force blood through the pulmonary trunk and then the pulmonary arteries. So the disease that affects the right heart is going to affect the heart function on a whole. So something like right ventricular infarction. So when the right ventricular muscle dies because of a infarction, then the pumping function of the right ventricle is going to be reduced. So you're not going to get blood going through the pulmonary trunk and into the main pulmonary arteries. So the blood is going to back up in the right ventricle, right atrium, the neck veins, and in the liver. So that's not a good thing. Some cardiomyopathy will involve the right ventricle, and some cardiomyopathy only involve the right ventricle. Okay, so something like a right ventricular dysplasia, right ventricular dysplasia, where the right ventricle is replaced by fibrofatty tissue, and of course fat does not contract, so it's going to affect the function of the right ventricle and the whole heart as a whole. Pulmonary hypertension, because blood cannot get through the pulmonary circuit, so pulmonary hypertension is going to affect the right ventricle, and the right ventricle tends to dilate when you have uh, pulmonary hypertension. Shunts, left to right shunts, so you're going to have increased blood flow into the right atrium, right ventricle, and as a result of that, the right side is going to enlarge. And then we touched on arrhythmogenic RV dysplasia. So it's a form of RV cardiomyopathy where the muscle in the right ventricle is replaced by fibrofatty tissue. And as we said before, fibrofatty tissue does not contract, so the function of the right ventricle is going to be compromised. So you're not going to get blood on the left side. Uh, so the patient is going to be symptomatic. All right. So, and not only that, they tend to have a lot of arrhythmia, the arrhythmogenic RV dysplasia. So again, you have to know how to distinguish the right ventricle from the left ventricle. Patients come into the echo lab, the heart is not labeled, and you're going to see a lot of congenital heart disease. So you have to know how to distinguish the right ventricle from the left ventricle. So one of the most distinguishing feature is the more apical insertion of the septal leaflet of the tricuspid valve as compared to the anterior leaflet of the mitral valve. So the tricuspid valve is lower in the ventricle than the mitral valve. The presence of the moderator band tell you it's a right ventricle. The right ventricle tend to be highly trabeculated, and you'll have more than two papillary muscles because you have a tricuspid valve situation. Okay. Again, the presence of more than two papillary muscles. The trileaflet configuration tricuspid valve, and the presence of coarse trabeculation. So you tend to have more trabeculation in the right ventricle. So you need to know the features that's going to distinguish the RV from the LV. Right. So we come now to the dimensions. You have to know how to measure the RV dimension to see if the RV is enlarged, yes or no. And this is what we call the RV focus view. So it's an apical four-chamber view, but you manipulate your transducer to see more of the right ventricle. And if you look closely, you can see that, so you get a tricuspid annular uh, measurements, and this one we call this is the basal measurement. Okay, so this is your basal measurement right here, and you're going to do a mid cavity measurement, and then you're going to drop from about the mid segment to the apex, the RV apex, and this is your longitudinal measurement. Okay, so these are the measurements you want to do. So you want to do your basal measurement at the tricuspid annular plane, and you can do your mid cavity measurements and the RV longitudinal dimension. So you see how the RV longitudinal dimension is measured. So these are the measurements that you're going to do to assess if there's RV dilatation, yes or no. All right, so what are the measurements we're talking about? And these measurements there's some slight changes in these measurements, but for the basal measurements, we talk about anything greater than 4.2, and for the mid, greater than 3.5. So these measurements greater than these numbers suggest RV dilatation. And then longitudinal dimension, anything greater than or equal to 8.6. So let's just go back and look at, okay, so this is your basal measurement. So if this is greater than 4.2, it suggests RV dilatation, and the longitudinal greater than or equal to 8.6, and the mid greater than 3.5. So it's important to do those measurements. You're also going to measure the right ventricular flow tract, and you're going to do a proximal measurement. You know, you can also do this one, but you should also do RV distal measurement to see if you have RV dilatation. So this is done in the the parasternal long axis view, and this is done in diastole. Okay, and then similarly, this is the short axis at the level of the aorta, and it's done in diastole. And then the RV distal, this is a slightly modified view where you highlight the right ventricular flow tract. Okay, so these are additional measurements to assess RV size. And so the distal dimension greater than 2.7 suggests you have RVOT dilatation, and then the proximal greater than 3.3 indicates RV dilatation. So when you, of course, this is measured in diastole. So if this is greater than 3.3, okay, proximal measurement greater than 3.3, and then if the distal is greater than 2.7, it suggests you have RV dilatation. So get in the habit to measure them because it's important to know if the RV is dilated, yes or no. What about RV thickness? You tend to get RV thickness if the patient has pulmonic stenosis. So you can do RV thickness in the in the subcostal view. You can do subcostal view, and you always zoom. So you always zoom because when you zoom, the error in measurement is going to be reduced. So you zoom it up and you measure the RV thickness. Anything greater than 0.5 centimeters or 5 millimeters suggests uh, RV thickness. So this is when you zoom it, you can measure it easier. You can also do M mode measurements as well. Okay. Um, okay. Subcostal view, one of the best, the best view to measure RV thickness. All right. So the RV wall thickness. So it is measured again in diastole, so in the subcostal view, or you can do the left parasternal view uh, in diastole. So if it's greater than 0.5 centimeter, it suggests increased thickening of the RV. So you have RV hypertrophy, and it is mainly seen when you have distributed pulmonic stenosis, hypertrophic cardiomyopathy, or infiltrative disease. So this should be pulmonic stenosis. Okay. All right. So how do we assess RV systolic function? So the size of the RV is important, and the assessing RV systolic function is also very important. So again, as we said before, we used to neglect the right side, but we know that that's dangerous because if someone have, say, an atrial septal defect, if the RV is enlarged, that automatically tell you that you have to fix the defect. So no, doing the measurements and knowing that it's enlarged is very important. Um, RV function. If someone has, say, pure pulmonary hypertension and you have reduction in the RV systolic function, that's very, very significant because it's telling you that the pulmonary hypertension is affecting the right ventricle and cause you're now getting a reduction in the RV systolic function. So you have to know how to assess the RV systolic function. And there are a number of methods. We use mainly just two though, but you need to be aware of the other methods. So the RV systolic function is affected uh, uh, primarily by right heart disease. Uh, so primary right heart disease that affects RV systolic function. So if you have anything, remember we talk about uh, arrhythmogenic RV dysplasia, where the muscle is replaced by fibrofatty tissue. So that would be a primary disorder, and it basically will just affect the right ventricle. You can have secondary uh, cause. So if you have a left heart, say a left-sided cardiomyopathy, which involve the right side, and that can affect the RV systolic function. Valvular heart disease. Okay, you might have a significant, say, mitral stenosis, mitral regurgitation, which, of course, the pressure is going to go backwards. You're going to get pulmonary hypertension, and eventually it can affect the RV systolic function. So doing the assessing the RV systolic function is very important. So what are the methods to assess RV systolic function? You can just look at it. If it's contracting well, you can see it. If the RV is contracting well, you can see it. So just visual assessment, but we have quantitative methods to do it. And you can do your fractional area change. It's a 2D measurement. So basically, you'll do the area of the RV. So you're going to do an RV focus view. So it's a apical four-chamber view, but you're going to manipulate your transducer to see more of the right ventricle. And you're going to trace the border to get the area. So you get the area in diastole, you get the area in systole, and what you do is subtract the area in systole from the area in diastole and divide it by the area in diastole, similar to what you do for your ejection fraction, but this is an area, it's not a volumetric thing, and you get the fractional area change. You can also do, this is very accurate now, tissue Doppler imaging of the tricuspid lateral annular systolic velocity. That basically, when you look at the lateral tricuspid annular, it's going to move up a certain distance, but it's going to move at a certain speed. And if the speed is reduced, then you have RV systolic dysfunction. You have reduction in the RV systolic function. Okay, it's supposed to be at a certain velocity. And then we have TAPSE, which is tricuspid annular plane systolic excursion. That is how much the lateral tricuspid annular plane moves up. It's supposed to move up a certain distance. And if it doesn't achieve that distance, then it's reduced. And then you can use your 2D RV ejection. This is more difficult to do. With three-dimensional echo, it's more doable. So you can have your RV ejection fraction, which is done similar to your LV ejection fraction. So that would be a volumetric assessment. So it's your diastolic volume, you're going to subtract from that your systolic volume, and you're going to divide by your diastolic volume. Okay? And then we have strain and strain rate. All right. So we're gonna leave this. So we'll come back to this on Saturday. All right. So we're not gonna do that. It's all right. So when we do area your fractional area change. So what you do in diastole, you just trace the area. So these are RV focus views. So the apical four-chamber view, but you focus more on the RV so you can see clearly. So in diastole, you trace the endocardial border, you get an area. In systole, you trace the area and you get a certain number. You're going to subtract from the end diastolic area the end systolic area. So the end diastolic area, end systolic area, you're going to subtract the end systolic area from the end diastolic area. You're going to divide by the end diastolic area. Okay, so in this case, it is 60%, which is normal. In this scenario, you do the same thing, it's 40%. So this is sort of borderline. It should be greater than 35%. Okay. And then in this case, when you do it, it's 20%, which is definitely reduced. So this would be our reduction in the RV systolic function. Fractional area change. It's not a volumetric measurement. It's a area measurement. Okay. All right. So we don't do it too much. Some institutions do it, but in general practice, we don't do it a lot. Um, so things that we do is or TAPSE and the RV systolic velocity. So when we do TAPSE, so this is, you know, most institutions do this, and you probably should do two methods. And the two methods that you probably should do is your TAPSE, which is an M mode measurement, and your uh, RV systolic um, RVS prime. So your RVS prime is a tissue Doppler image assessment, and what you do is uh, you put your cursor at the lateral tricuspid annular plane, and you just press your TDI button, and you get a velocity. With TAPSE now, with TAPSE, um, you do the same thing. So the lateral tricuspid annular plane, you put your cursor there, but instead of pressing your TDI button, you press your M mode button. It's a longitudinal uh, measurement. So TAPSE stands for tricuspid annular plane systolic excursion. It measures the distance of systolic excursion of the RV annular segment along its longitudinal plane. So it's an M mode measurement. So use the apical four-chamber view. Place your M mode cursor at the lateral tricuspid annulus, and the number we use now is 1.7. So anything less than 1.7 suggests RV systolic dysfunction. So TAPSE is done like this. So apical four-chamber view, cursor is at the lateral tricuspid annular plane. You press the M mode button. M mode button. So you're gonna, so your ECG is right here. In systole, the tricuspid annular plane is gonna move upwards. And so when you look at your M mode, it goes up, and you just measure it. So anything less than 1.7 is abnormal. And then the other method that you should be using is the assessment is your tissue. Well, that's what we just mentioned before, the TAPSE, your tissue Doppler derived S prime. Tissue Doppler derived S prime. So it's a tissue Doppler imaging method, apical four-chamber view. Your Doppler sample volume is placed at the lateral tricuspid annulus, and you just press your TDI button. It's a Doppler measurement. So you get the S prime velocity is the highest systolic velocity. So in systole, the tricuspid annular plane is going to move up with a certain amount of speed, and that is what we're measuring. You're measuring the speed. Okay, so that's why we say it's S prime tissue Doppler. So if your S prime, and the current number for this is 9.5. If your S prime is less than 9.5 centimeters per second, it suggests RV systolic dysfunction. So, you know, all labs should be putting out these numbers. Okay, all labs should be putting out these numbers. We're gonna, so again, when you do your RVS prime. So you're going to get something looking like this. So this is your systolic excursion. These are your diastolic excursion. The first one is your E prime, and next one is your A prime. This is what you're going to measure. The S prime should be greater than 9.5. Okay. All right. So we want to stop at the RV systolic function, and what we'll do, on Saturday we'll pick up. Okay, so all labs should be doing these assessments, uh, especially if you do your TAPSE and your TAPSE is borderline. You have to do your RVS prime. Okay, a few labs are doing fractional area change. If you have a three-dimensional system, you can do your RV ejection fraction. Um, but at least two methods to assess RV systolic function. So on Saturday, we're gonna do right atrium, and we'll see if we have enough time to go over the changes in valvular heart disease. All right.